I had the honor to, see these abstracts and get to give the sort of first opinions on how we can integrate some of this into clinical care. But these are two really great abstracts on non-clear cell kidney cancers, which is a subset of kidney cancer that's been historically very difficult to treat and very difficult for us to know how to treat. And historically we have taken the data in clear cell kidney cancer and then a few years later translated into non-clear cell kidney cancer to see if those agents that we've developed for clear cell cancer work in non-clear cell cancers. And so both of these abstracts try to do some of that, and the CALYPSO trial also tries to combine some newer therapies with papillary kidney cancer specific treatment. And so KEYNOTE-427, they're presenting the second cohort, cohort B, which is the non-clear cell cohort, and it's a trial of first-line Pembrolizumab in non-clear cell kidney cancer. It's really the first prospective data that we have looking at an immune checkpoint inhibitor in non-clear cell kidney cancer. There's been several retrospective studies that have been small that demonstrate some activity, but this is really the first time that we have prospective data to support the use of immune checkpoint inhibitors in non-clear cell kidney cancer. And so, I think the abstracts, the KEYNOTE-427 data looks really promising for non-clear cell kidney cancer. I think it represents a new standard treatment option that we have, which is something that we couldn't say before this abstract came out. I think a lot of people have been using these agents in this disease setting anyway because it's so historically difficult to treat. But I think that this gives us a lot of validation to doing that. And for patients that can't get first-line VEGF receptor tyrosine kinase inhibitors for whatever reason, this is a very viable first-line strategy and, may even overcome that with more randomized data. The CALYPSO trial sort of similarly looks at the anti-PD-L1 agent Durvalumab, but combines it with a MET inhibitor, Savolitinib, which has some good Phase II data to support its development in specifically papillary kidney cancers, which have a lot of MET alterations. So, this trial was designed for patients to start on Savolitinib, and then 4 weeks later, they add the Durvalumab. It actually shows relatively similar response rates to the prior one that we discussed. And I think it has, again, some prospective data to support immune checkpoint inhibition, as combined with the prospective data that we've seen with Savolitinib in the past with the Phase II trial. I think it is interesting to learn how to combine some of these targeted agents with immune checkpoint inhibitors in papillary kidney cancer. This trial did not meet its sort of primary endpoint of response rate of greater than 30%. I think some of that has to do with the fact that Savolitinib is very specific to only the MET receptor, and whether this is the ideal combination for papillary kidney cancer, I'm not sure, but I do think that it's a good pilot and prospective data on combining targeted therapy and checkpoint inhibitors. We've seen a lot of excitement around that in clear cell lately, including a couple abstracts at this conference. So I think the future of the combination therapy in non-clear cell kidney cancer is likely there. And I think that this is a good start. I think we still have a lot of interesting studies to come out on the use of MET inhibitors in papillary kidney cancer and how to combine those, or if to combine those with checkpoint inhibition is an outstanding question, I think.